Thank you very much. I'll try to present you the data. Can I have my slides, please? The data on bariatric tourism in Europe. Of course, it is very hard to assess that. So what we did, we made a survey and sent that survey to all the presidents of the European national chapters. Can I have my slides, please? And finally, 19 of 28 presidents responded. Fantastic. If you could bring it to the big screen too. Thank you very much. Okay, my disclosures. So here you see the 2016 numbers of bariatric procedures all over Europe. And medical tourism is nothing new. People from Austria drive to Hungary for dental tourism. People from other countries go to the Ukraine. They promise low costs, high quality, best vacation. The same might be true for other countries, for cosmetic surgery, and even the Royal College of Surgeons is advertising and trying to bring people to them. So, as I mentioned, a 23 items questionnaire on bariatric tourism, return rate 19 out of 28, and the presidents of the national societies. And one question was, of course, in most of the countries, the public health or the healthcare insurance stick to the IFSO criteria, meaning BMI 35 plus, comorbidity, or more than BMI 40. And the exception are countries that have no coverage by the public healthcare provider, which accounts for approximately 1/8 of these countries. Why are people traveling to undergo bariatric surgery? Cost issues, yes, there is a substantial difference in costs over Europe. I'll give you an example. In Romania, a bypass or a sleeve costs approximately 4,500 euros, whereas in the most Western European countries, approximately 8,000 euros. And furthermore, there is a difference between private and public sectors, saying that in most of Western European countries, the private sector is more expensive than the public sector. So these are the numbers I received from the presidents, and you can see the estimated bariatric tourism all over Europe is not that big. Netherlands, for instance, less than 200, they have a very strong public healthcare system. Germany, 500, considering that they're doing 10,000 operations a year. They have long waiting lists, a little bit higher. Austria, 200, also not that big, and you can see the rest on your own. From Slovenia, Greece, Belgium, UK, and Portugal, we did not receive any data. So what is the benchmark to travel? The threshold. It must be more than 25% in most of the cases. If the difference is more than that, then are people willing to travel and to make bariatric surgery elsewhere? And where are they going to? The three most common countries people are going to is Turkey, followed by Czech Republic, and number 3 is Belgium. And what are the reasons to go to another country? The most common reason is in approximately 1/3, no insurance coverage. Number 2, they did not meet the IFSO criteria, and on almost the same range for personal reasons. Which operations are done? Mainly sleeve and Roux-en-Y, just in a smaller number, one anastomosis, gastric bypass, and the rest not to be mentioned. Favorite destinations from countries outside Europe coming into Europe or within Europe is number 1, Middle East, followed by United Kingdom, and number 3, Russia. What are the reasons to come to other countries? Is number 1, healthcare system, which means people coming to that country believe that the healthcare system in this country is better, followed by insurance issues, and number 3, personal reasons that could be that your family comes from that country or other personal reasons. What are the operations that people from other countries coming to that country receive? Again, majority sleeve with almost 50%, followed by Roux-en-Y gastric bypass and one anastomosis gastric bypass. In this setting, the one anastomosis gastric bypass a little bit more often. We also asked the surgeons, do you think that people having surgery as bariatric tourism have appropriate follow-up? And as you can see, 15 surgeons said no, they have no proper follow-up. Only 3 thought yes, they would have follow-up that is appropriate. How can we improve that follow-up? Maybe by e-health and online support system, easier access at the local hospitals, and enhance communication between countries. There was major concern against bariatric surgical tourism, and it is very clear, and this is already my conclusion, the big majority of procedures is done in domestic countries. Bariatric tourism only accounts for a really minority of procedures, and we have also a small number of people doing operations with indications outside the IFSO criteria, and maybe we need European standards without exception and adequate follow-up. Thank you very much for your attention.
Thank you very much, Dr. Prager. Now we're going to have Dr. Kazama presenting the Asia Pacifico chapter. Go ahead, please.
Thank you. Could you give me my slide? My slide, please. Okay, so I'd like to talk about the bariatric tourism in Asian Pacific chapter. This is disclosures. So now Asian Pacific chapter has 11 countries. So that I sent some questionnaire to all the presidents here, and they all replied to my questions. So the first one, is there a bariatric tourism in your country? Yes, it's 10. No, just one in our country, Japan. But very limited is 3. So President's opinion, the 8 agree with medical tourism, but the 3 presidents are very limited agree. And the estimated bariatric tourism per year is 4,500 cases per year in Asian Pacific region. That's totally 6.5% of the surgery in our region. And the number of the bariatric tourism, a percent of the bariatric tourism, the 0.5% is a 6 country, and 0 to 10 is 2 country, 10 to 20%, 2 country, and it's interesting. Philippines has the more than half of the bariatric surgery is for bariatric tourism. So top 3 countries for area from is the United States and the Middle East. The 3 countries included in the top 3 of the United States and Middle East, and the 2 countries are China, Iraq, Afghanistan, Russia, and one is Micronesia, and Indonesia, and so on. So all countries who do the medical tourism provides a sleeve gastrectomy, and the 70% country provide the Roux-en-Y gastric bypass, and the others are like this. So reason for bariatric tourism is the high quality of surgeon reputation from the area with less bariatric, and the cost are from the United States. The age or limited to 30 to 50, and female dominant. So patient selection, upper limit is majority are 60, BMI 60, and the one country says that BMI 45 because of the follow-up is poor. And ASA, the PS limit is a PS limit to 1 or 2. So average cost of procedures, so the bariatric tourism procedure averagely $1,200 US, and the domestic procedure is 1,000 US dollar. So difference is 0 to 17 US dollars. So 4 countries provide no difference between their national person or the person from abroad. But one country provides 17,000 US dollar difference. So pre and post care is, every country says it's exactly the same. And pre-op consent is 8 countries said enough. The post-op stay is averagely 10 days. It's of course more than longer than usual. So follow-up, majority of them follow up by internet, and 2 countries ask them to travel back and the face-to-face follow-up. And the 2 countries limited alliance center or referred physician. The 3 countries just go home and say goodbye. So risk of medical tourism is a poor follow-up and complication management. And the other one said that the improper patient selection, and the one president said that the surgeon's attitude, money versus responsibility. And one country which has the accreditation system said that its risk may be reduced down by accreditation center of the domestic society. So this is the conclusion. Bariatric tourism is accepted in most of the Asian Pacific country, and 6.5% of the bariatric surgery in Asian Pacific country are the bariatric tourism. And the reason of the bariatric tourism is the cost and quality, and the follow-up is mostly done via internet. There's still some problem that may be better to buy the designated center. Thank you.
Thank you very much, Dr. Kasama. Now we are going to ask Dr. Misra to present the KSA MANAC chapter.
Okay, just to start the slide, in our area, MENA area, it is becoming very active these days, and so growing very fast and active, especially in the field of bariatric surgery. And most of the reason patients moving from among these areas, the first reason is just the cost, then go for quality. So this is why people moving from country to country. We are 6 countries: Saudi Arabia, Kuwait, UAE, Egypt, Jordan, and Lebanon. Some of these countries, they have history and advanced and good history in the field of tourism. So if we talk about countries' hospital joint commission, this is a recent issue which all governments start to insist about the quality to improve their hospital. This is in 2013. You see, especially in some countries like Saudi Arabia, they're taking care about the quality very, very seriously. And it was 2013, and it is now more than these 42 hospitals almost become mandatory to have a GCI or any accreditation for your hospital or any hospital, especially by Ministry of Health. Anything come by stick makers or the stakeholders, it will be work. So this is one of the important things in this country to improve the quality. So we do care about the quality in these countries. Bahrain is one, not because it is they don't care, but because it is a small country. This is why they are it's only hospital. But I'm sure recently and this year almost 50% of their hospital they get the accreditation of the quality. Dubai, they are going very fast and very attractive, and they're making almost 1.4 million of Dubai in 2016. This number increased by every year by 10 to 20%. Why is Dubai? It is having the 2 issues, the quality and it is an attractive city. But it is not low price, it is a higher price. So one of the examples of quality and attraction is Dubai. So, and they have a good experience and they're working in this field long time. In Saudi Arabia, we have a lot of issues. Ministry of Health is the national service of the entire population. This is The new thing recently, last 1 to 2 years, it is becoming privatization of all the services in Saudi Arabia, including the health services. Now they are in the program of privatization. So they are aware about the medical tourism, and they are working very hard. Most of the tourism in Saudi Arabia, it is religious, and they are making a lot of almost 14 billion annually, and it is the third largest for employment. So the demand for medical service is very high, and with the new government and young decision maker group, they are working hard to increase it. I just, for example, if I tell you during religion days or occasions, hospitals in the eastern province, in the western part of that, it's full, especially private, 100% full, because of these patients. They come for treatment and they come for a religious region. But in that area, Jeddah, and in this east western province, close to holy areas, it is full. You cannot find bed during this period, and it is a large cities. Jordan, as I said, they are having a good experience in this field. Jordan, from the beginning, a historical city and very nice, attractive, and the cost there is lower than the Gulf region. Why? And also the standard of care. They are highly quality medical service and attractive and low prices than the Gulf, especially the Gulf region. The other thing, during bariatric surgery era now, it is the most attractive for the patient to go there because of the price. Now, this is the issue. The cost is very, very, compared to Gulf region, almost half of the price. For example, in Gulf area, the cost of bariatric surgery, 10,000 to 12,000 US dollars, while in Jordan and Egypt, which is attractive for tourism, it will cost $3,000. So make big difference. In the Gulf region, it ranges from 5 to 12,000 based on your hospital standard. And as you know, the number of bariatric procedures is very high in the area. So most of the people go to the Jordan long time. It is from Yemen. If you see Yemen, because of the medical service in Yemen is not up to the standard. Libya and Palestine and Sudan, and nowadays, most of the patients go to Jordan for bariatric procedure because of the price. Kuwait is compared to Saudi Arabia, it is a small country, but their government taking care of the health system, and they provide everything almost free. But it is not attractive for bariatric surgery because the price is the same like other countries in the Gulf region. But they do care about the health services, and they are doing fine in that part. Bahrain, it is almost second to smallest country after Qatar, but it is more attractive than private business and tourism in Bahrain more than Qatar. Even it is almost the same size, but because Bahrain more attractive in tourism and the visa issue and also the price and the standard of care there is very, very good and very high. This is why it's the most attractive in the Gulf region. For us as a Saudi Arabian, we have clinics there and we operate there. We bring our patient to Bahrain because of the cost, and it's only 1 hour drive. So it works with Bahrain. Lebanon also, they have a very nice and long history in the field of tourism, well organized, very attractive, and quality. So they have all three important reasons for people to go there: a beautiful visa issue, stable, and good high standard, and the price. So it's also very attractive for medical tourism among the countries. IFSO countries. And I didn't mention Egypt. Egypt also becoming now one of the most attractive for the patient. Again, for the same, most of the important reason for our patient is the price, and easy to go to Egypt, and large number of bariatric procedure and health. Egypt become attractive for our patient because of bariatric surgery. But this is the one which make Egypt now very high, attracting our patient to go to Egypt. Thank you very much.
Thank you very much, Dr. Misra. Now Dr. Behrens will speak on behalf of the Latin American chapter.
Thank you very much. My presentation is in an Excel format, please. Thank you very much for staying here, accompanying us to see what this is medical tourism. As I understood, these only are statistics. So in Latin America, we are 17 countries. This is what I'm going to show you, please, here. Okay, so that's what I decided to put it in Excel format. As you can see, I put it as a country. The best country for medical tourism in Latin America is Mexico. As you can see the numbers, read it, depends on the state, but Baja California does 155 cases per day. More of them in Tijuana, and this is because they are in the border. They are receiving patients almost from the US, from Canada, and here Dr. Bourbon is telling me that they are receiving cases from Australia, New Zealand, and other places. We in Guatemala, in 2018, we only did 108 cases, just medical bariatric tourism, because this is medical bariatric tourism, no medical tourism. That's why I'm doing and put exactly what we have. El Salvador, 84 cases, 2018. You see the percentages there. Honduras do not report anything. Costa Rica, 7 cases per year from USA and Canada. Panama do not report. Venezuela, they said did not report anything because they're in trouble. Up, please. Can you move the presentation up, please? Thank you. Colombia is the second country in Latin America that is doing more bariatric cases, 500 cases per year. And the Colombian says that these are Colombians that live abroad. They're coming from Spain, they're coming from United States, from the USA, but more from Europe. Okay, Peru, 80 to 100 cases per year. Ecuador didn't answer our questions. Bolivia do not report anything. Paraguay, 10 cases per year. Up the presentation, please. Chile says there are few cases because some of them are going to Peru, and these are done by 2 surgeons from Peru. Argentina do not report that. Uruguay do not report that. República Dominicana did not report. And that is my presentation. Thank you very much.
Now, Dr. Jaime Ponce will speak on behalf of the North American chapter.
So what I'm going to do is use this few minutes to give you an update on a couple of things. You know, our numbers, what is the status in the United States and Canada, and then, unfortunately, we don't have a good database on medical tourism. Do you have my presentation? Ahí está. Rápido. Entonces, the chapter, North America chapter, of course, we only have 2 countries in the IFSO chapter, Canada and United States. And as you can see around the world, we have a large number of high percentage of obesity. This is the latest published CDC statistics in regards to obesity. And as you can see, most of the states have more than 30% of the population, close to 30% of the population being obese. When you start narrowing the adult population, more states have more than 35 and even more than 40% of the population being obese. And it is estimated, if you follow these graphics, that by 2030, the majority of the states are going to have more than 50% of the population being obese. So this is continue to grow, and it's becoming, this is a picture from the CDC, one of the problems that we have in the United States. Now, one of the biggest distractors that we have in the growth of numbers was with the laparoscopic surgery. These are the latest numbers that we had in the United States, 228,000 cases in 2017. The unofficial numbers for 2018 are around 252,000 cases. Sleeve gastrectomies continue to grow, and bypass actually continues to decrease. The bands now are 1% of the cases, and then you can see the rest of the numbers. So this is interesting. We grew 10% from last year to the following year. And this is the difference in procedures. It's still the sleeve becoming the most common. And if you look at the number of revisions and bypass, they're very similar. Now, membership of the SMBS continues to grow. And if you look back in 1998, we have 250 surgeons. Now we have 2,500 surgeons. That's 10 times more in 20 years. The same thing of number of procedures, 10 times more. Now, Canada numbers is interesting. They do have kept track on those numbers. And back in 2006, they were doing about 1,500 cases. When you look at the numbers of 2018, they did 9,000 cases. Most of the cases were sleeve and bypass, bypass being a little bit more than, sleeve being a little bit more than bypass cases. Now, medical tourism in the United States. So the United States, actually, when you look at people going to other countries, the United States is the biggest source of medical tourism to any place. And so it is interesting, the 176 countries get American patients to have some kind of medical tourism. We do not have any specific information on bariatric surgery. It's very difficult. If you ask a couple of different sources, the estimated number were in between 25,000 and 50,000 cases. So I am very surprised that you say that there are like 55,000 cases in Mexico. And probably the majority are Americans, correct? The majority are Americans. And so sources are very difficult to obtain. But it is what we think is about 50,000 cases, which it correlates. But some of those cases are going to Costa Rica and Central America. Some of those cases are going to South America. Some cases are going to Europe and Asia, but there are very few cases. The majority are going to the border towns. Now, when you look at the reverse medical tourism, when a patient's coming to the United States to have surgery, it's very minimal. I did a search on most of the practices that answer a survey, and most of the practices said that they're seeing 0 to 1 patient coming from another country per year. Basically, it's not existent in the regular practices. Now, there are big centers that are famous that traditionally have had a lot of medical tourism for cardiac surgery, for different things, and those centers actually are doing some patients from other countries. And so, let me just show you this. Institutions that do the most medical tourism coming from other countries to the United States are Cornell University, 20 cases a year, Columbia Presbyterian in New York, 6 cases a year. That's last year. University of Miami, Florida, Nestor de la Cruz, 10 cases. Cleveland Clinic, 40 cases, and that's the place where we do the most cases. UT Houston and with Eric Wilson, 15 cases. The Harvard Hospital Systems is also about 15 cases. Cedars-Sinai Hospital in LA, about 5 cases. Johns Hopkins in Mayo Clinic, which is not included on this list, they do about 10 to 15 cases a year. And Duke University, which I thought they were doing more cases, they say that last year they only did 2 cases coming from outside the country. So those are the most tourism that we have. So when you look at that number compared to the number of Americans having surgery, it's probably around 0.01% of the cases. So it's not a significant issue in the United States. People coming from other countries and have surgery in our country. Thank you.
Okay, now we have 3 more presentations, and the first one is from Dr. Estuardo Berens, and he's going to tell us how does the business work.
Please, medical tourism presentation in a PowerPoint. The reason, Jaime, that the United States is seeing less cases now is because of the price. Almost 60 to 80% less than the price in the US. And that's the main reason they're doing.
Lack of insurance and price. So they don't have insurance coverage, and then the price is low.
Absolutely. Absolutely. So that's the main reason. And before, when the bariatric surgery, medical tourism presentation in PowerPoint, please. Oh, yes. Okay. Thank you. So how is this working? What we do with the patients? Okay? This is the definition of what is medical tourism, and we have to know it in bariatric surgery. What is the reason? Patient seeks lower cost, no wait list, and medical expertise. Sometimes the indications of bariatric surgery, sometimes they're abused in one of these countries. So we have to take care of that because the numbers are increasing and increasing and increasing. I'm thinking that these guys in Mexico and Baja California, they're doing a great job. They're doing a great job, but some of them are not. So I think now you have to control very well that. What does the patient has to see when they are considering medical tourism? Query for medical treatment, you can see, I am not going to read everything what is in here. You can read it better than me. Scheduling and planning, arrival, that's what we offer to our patients. A hotel near of the facility, a complete medical evaluation, a complete workup. Doctor, I have here my results in my country. Okay, let's see the results. Okay, we're going to do the tests again. So we take at least 24 hours. All these patients are coming to our facility with at least 15 days of a pre-op diet. So all the protocols are done. We perform those exams on the day of the arrival. You can see that are all the things that we do with the patients. If patient has a medical condition, we require to send the internist, the pulmonologist, and the cardiologist always see these patients. We do always a preoperative endoscopy. Doctor, this is my endoscopy 3 months ago. We do another one. How much cost is an endoscopy in the United States, Jaime? $2,000? How much cost the... Yeah? Okay, $1,000 in our country could be $200. So we can do it preparative. It is mandatory that medical tourism procedures be performed only in certified hospitals. This is a rule, and only by experienced and certified bariatric groups. These are all the indications, the ideal indications of bariatric medical tourism. This is the medical questionnaire we made the patients to fill. Everything is going to see here. You can see about allergies. You can see about the problems of asthma. And we do a special sheet about reflux. We think that this is a very, very well performed gastroesophageal reflux. This is extensive questionnaire because nowadays the most performed bariatric procedure is sleeve gastrectomy. So sometimes we do manometry on these patients too. The interdisciplinary questionnaire is important. Psychologists, nephrologists, the interdisciplinary group must be accompanying us and counseling our patients before all the surgeries. Most patients must follow a preoperative diet 2 to 4 weeks before arrival. This is given by the nephrologist during the preparation for surgery. Thank you.
Now, Dr. Chetan Parmar is going to tell us how possible it is to offer good quality of service in bariatric medical tourism units.
Okay. Thank you, everyone, for staying around till late. I did anticipate this, and therefore, just half an hour ago, I went and deleted about 20 slides from my presentation, so hopefully we should be quick. Now, when we talked of developing guidelines by the IFSO for bariatric medical tourism, the first thought which came was, well, let us first understand what our views as the IFSO members are and what do we understand by bariatric medical tourism. And I think that's why we structured this survey to see what are your views. And thank you, those who answered the questionnaire. If people who have not answered, this is the link which is still active, and I would request you to take the questionnaire. So I am basically going to present the result of the survey, which will be then followed by Nelson, who will talk about the guidelines. This is the analysis. So 380 IFSO members answered the survey from 64 different countries around the world. 92% of them were bariatric surgeons. Rest were allied health professors, dietitians, and all. The total experience of this cohort was a whopping 233,000 patients' experience. So that's a lot of experience to share. Majority, as you can see, were in private sector. Again, majority saw them as an elective scenario, and the next common was a combined elective, or they encountered these patients in a complication scenario. When we asked them how many patients they were seeing from a month, it ranged from 1 to 5. When you look at the others group, actually, those are units like Dillemans who have mentioned thousands of patients there. Majority of these patients were in the age group 26 to 40, and I think a couple of those surveys of you guys showed the same, and majority of them were females. I thought that gastric band was the most commonest procedure performed as a bariatric tourism, but no, that's not the case. Sleeve is the #1, Roux-en-Y second, and interestingly, mini gastric bypass is #3 now, and adjustable gastric band comes, I think, #5. Now, this is worrying. You would assume that high quality care would be the main factor for bariatric tourism, but that's not the case. It's cost, cost, and cost. So 78% travel cross-border only because it is cheaper. And you give them 25% discount to 50% discount, and they are happy. I think majority of us understand correctly that bariatric medical tourism is in the top 3 to 5, as you showed up, Estado, as well. Now, word to mouth, still, even in this online age, was considered as the most favored online, or most favored modality of advertisement, followed by online advertisement. And referral by colleagues and friends was the third most common scenario. Now, again, this is worrying. If you look, yes, the green looks better, but 45% of us believe that the patients are not provided up-to-date and satisfactory information. So that needs to, I think, in the guidelines, that really needs to be addressed. And when we go in detail, preoperative workup, if you look, I think nearly 30% think that there is no preoperative workup. Patients just turn up and they have an operation. 2, some people think that 5 to 7 days was an optimal workup. As a part of preoperative workup, bloods, ultrasound, upper GI endoscopy score high, but then look at the MDT discussions and stuff. They are all complex patients. Only 35% of them actually have an MDT discussion. Only 30% of them have sleep studies. Eating disorder, less than 40. So those all things needs to be improved in the guidelines. Again, this is worrying. Majority, 51% of the patients are, we think, not offered surgery as per the international guidelines criteria. When we asked about the upper and the lower cutoff limit, I think majority agreed that BMI 60 should be the cutoff for the highest range, and majority were of the opinion that less than BMI 30 should not be offered bariatric surgery as for medical tourism. Understandably, ASA 2 and 3 was satisfactory to perform operation. When we asked what should be the experience of these surgeons, it varied. It was a divided house from 50 to 100 to 1,000. Again, 30% thinks that the patients are not consented appropriately, and there is a mismatch in consent and language when consenting is done. Post-operative stay, I think it varied from 3 to 7 days. 380 responders thought that we should, at least the patients should stay in that city for at least 7 days. Again, when it comes to discharge summary and post-operative documentation, 80%, nearly 80 thought that they would get that, but still 25% thought they would not know what operations their patient has had. Understandably, everybody agreed that we should have a liaison surgeon or a friend so that you can phone a friend in your home country. When it comes to a follow-up, I think we are catching up with the internet and media guidelines. So majority agreed that an online protocol or a WhatsApp or a Skype interview should do the trick. When asked about risk associated with bariatric medical tourism, look at that. Poor quality post-operative care scored high, nearly 90%. But overall poor results there, that is nearly 40% as well. So And mortality, 12% of us think, no, so majority think that patient would have high mortality as well. Now, I think somebody talked about international healthcare accreditation. 51% of there, 51% have no clue what is international healthcare accreditation. 30% knew, but their hospitals are not. And I think that, again, probably needs very strongly addressed as a part of these guidelines. I think this is correct. We should approve for insurance covering this operation. IFSO and ASMBS endorsed operations should be offered. Majority agree with that as well. Interestingly, 30% think that the surgeon offering this operation should not be a subject of litigation. And when you break that question further, 12% think that the patient should be responsible, which was interesting. Yeah. I think majority agree that it is ethically right to offer operation. Majority felt that they were comfortable dealing with the patient and the complications. Now, the complications encountered, poor weight loss, and interestingly, nearly 70% had problems with reflux. Anastomotic leak was next, and then came bleeding, and malnutrition was a big issue as well. I think, understandably, in this era of globalization, we can't just ignore bariatric medical tourism, and I think we do all need to agree that there has to be a better coordination between countries and hospitals. Nearly 90% of you agreed that we should have an international forum to discuss this and come up with the guidelines. So that's the survey. I will stop at that, and I think Nansen will then carry on with the guidelines. Thank you, and if anybody has not taken the survey, they can take that, and we can write it up. Thank you.
Thank you very much, Dr. Parmar. And now the final presentation for this module is guidelines and requirements for bariatric medical tourism, safe practice. It will be presented by Dr. Nelson Rodriguez.
Good afternoon, and thank you very much to join us this time for this session. Okay, this is the result for a position statement that we worked since the last year in 2018. And we have to understand that the medical tourism that is new. Thousands of years ago, the pilgrims traveled to around the world to get medical service. But this practice, we have to understand that the motivation is the financial, okay? Maybe in the last years or many years ago was for better services or best quality of surgery, but right now it's only by the financial in many countries, and that's happened in Mexico too. And Mexico is the second country around the world for medical tourism. That results are to 2012, but include all the specialties, not is only for bariatric surgery, but we are the second after Thailand. In Mexico, we have most of the procedures for bariatric surgery in the border, like Baja California, Sonora, Tamaulipas, and in some states of the middle of the country, like Jalisco, and in the Quintana Roo too. And this position statement starts in 2018 in alliance with the Academia Schoolab. And this project was inside for the Alliance for the Surgical Patient Safety. And in Mexico, we are working with another associations like the boards, like the General Surgery Association, Endoscopic Surgery Association, but it's supported by the Academia Schoolab. We have to understand that for this position statement, we use the Delphi methodology. This methodology has been used, for example, for the laparoscopic cholecystectomy for the safe surgical practice. Has been using for ERAS too, and we use for this position statement for bariatric surgery in medical tourism. Our task force was integrated by 30 surgeons, like the experts group, but we have to include another surgeons like the control group. For the expert group, all the surgeon was in the border, and the control group was for for all the country. And this is the stages for this position statement. In the first part, we perform a survey for the diagnosis, like the survey 10% Chitan, something similar, but was only included for the Mexican surgeons. The second stage was the specific survey for the position statement, and we performed 2 rounds. And after that, we analyzed the results, and we performed the requirements and recommendation. It's important to say that for this position statement, we use specific questions using the Likert scales and integrated by 5 questions. And that is the results for the requirements and recommendation of the safe practice. We can divide this position statement in 3 parts. The first one is for the pre-operation. The second one is about the bariatric surgery, like to the place, like the surgeon. And the third part is for the patient follow-up. Our association recommends that all the patients should be evaluated before arrive the country. And they have a contact with the multidisciplinary team, and they will be to perform the surgery. Another recommendation is that the evaluation should be in person when the patient arrives at the hospital. Not only is enough with a remote evaluation or online evaluation. And it's recommended that we have to take new preoperative tests inside the hospital, not only for the country's patients. We have to retake new ones. Another recommendation is that the patient should arrive at the hospital center at least 24 hours before the surgery, because in some cases, the patient arrived the same day, and the same day is going for the surgery, and that is safe because we can have problems like thromboembolism. Not is acceptable to perform surgery in patients with high BMIs for the high risk. In our position statement, the conclusion was no more than 72 BMI. And that is acceptable perform surgery in patients with low surgical risk using the scale for ASA, like 1 and 2, no more. For the second part for the position statement, when we talk about the bariatric surgery, we can conclude that the patient should have an adequate process for the informed consent. The bariatric surgery should be performed by a certified bariatric surgeon. In Mexico, we have a specific program for certified surgeons for bariatrics, and they have to have an average of 100 bariatric surgeries per year. Another recommendation is about the hospital. In Mexico, we have a specific process to certify hospital, and it's something similar to the Joint Commission. We can put in the same scale, but our recommendation is that the patient use a certified hospital, then they have all this infrastructure for all the high-risk patients, like intensive care unit, blood bank, radiology, 24 hours emergency, endoscopy, and all the medical supplies in an appropriate process. What is important too, the type of surgeries. Our position statement said that the type of surgeries performed should be approved by our federation, by IFSO. And another important topic is to perform bariatric surgery using medical supplies approved by FDA in patients, and they are coming from the United States. In what's up or what can say about the patient follow-up? We have some recommendations too. It's mandatory that the patients remain in the city at least 3 days after the surgery to check it and everything is okay. And it's considered mandatory to have a medical summary and a post-op X-ray text for every patient before the patient leaves the country. It's mandatory too, and after the surgery, all the multidisciplinary teams should be in contact at least in the next 6 months. We recommend one contact at least at the first month, 3 months, and 6 months. And our association considered necessary and had a priority to have a surgery because this is a big problem because we don't have a specific surgery in Mexico for bariatric surgeries, and sometimes we cannot give exactly numbers about the complication or low incidence, and this is difficult, and we have to work in a registry. And what is the conclusions? Let us not forget that the great majority of these procedures have excellent outcomes, and all the complications could happen in any place. Maybe it can happen in Mexico, Guatemala, Chile, and it's the same in the United States. And the global healthcare is a support for all those patients that cannot afford the cost in bariatric surgery in his own country. And we have a lot of things to do, but we have a compromise like country to give better outcomes, to give a more safety bariatric surgery. Thank you very much.
Thank you very much, Dr. Rodriguez. I think we can spend at least 10 minutes trying to have a discussion. What I learned from the presentations, from the first set of presentations, is that medical tourism happens everywhere. Other thing that I learned is that people is concerned about patient safety, and that the main driver for medical tourism is financial problems. So to have generalized coverage, health coverage would be ideal, but that's not going to happen, at least in the short term. So I think we need to improve the medical tourism, to have regulations for medical tourism in order to make it safer for the patient. So what I would like is to ask the presenters if they think that there should be a regulation and who should run that regulation. Here is a microphone. Okay. About how to make a regulation for medical tourism. Who wants to answer that? Do you think that's needed?
Well, Miguel, I think, coming from the United States, I can tell you that if we do not have regulation, what we're experiencing right now is a business in medical tourism, meaning that there is all these internet companies that are recruiting patients that don't have insurance coverage, and they wanted to have the surgery cheaper, and they're recruiting those patients to go outside of the country for those surgeries. They're also partnering with surgeons in other countries to take those patients there, including in the package the travel arrangements, and the only thing that they're not addressing is the quality of the care, the hospital instruction, preoperative care, post-operative follow-up. They just wanted to do the surgery and come back. There is the Joint Commission in the United States, which everybody's familiar because there's an international version of the Joint Commission. And I do think that some way, somehow, we need to try to get an international accreditation, at least to set up a standards of how these patients need to be taken care of, and probably also set a communication with the country of origin to address the follow-up. We all know that the follow-up is needed. So I wouldn't mind if Nelson called me and said, there's a patient that really wants to come and see me, and here's the information, and she doesn't care paying for the follow-up, but can you help her to take care? I would do that. I've done that. There were many bands that were done before that didn't have adjustments in Mexico, but they came to me, and surgeons like Rumbaut and all the Monterrey surgeons and Tijuana and Ariel and all the stuff, they send me surgeons. But now, they're not arranging that follow-up, they're just throwing it back. And so, I think there has to be some regulation, yes.
I think until the governments don't get involved, how much ever regulations as societies we put, it's not going to make sense at all. Because we need some kind of policing for the regulation. We have many guidelines and stuff like that, but nobody really follows those guidelines. For example, we saw Mohit show one case of a patient with a BMI of 110 that came. Your guidelines say that above 70 he should not be operating. So when a patient goes to someone who's an expert, it's assumed that ASA1, ASA2 or whatever, he would be able to manage that. The question is, only thing we could do is we could certify these centers whether they are good enough for performing the right bariatric surgery. I think that's probably, as a society and as someone which is a world body, we could just do that. I don't think anything else without the government support will make sense. For example, Thailand invests so much money into getting medical tourism, and Dubai for another country. So these are countries where the government pushes for medical tourism, so they won't have too many tight laws around it.
I fear when we accreditate the centers that attract patients from other countries, we create even more bariatric tourism. In my mind, the best way, personally, I think it's not good, bariatric tourism. People should stay in their own country and be operated there. And we see in those countries with strong public healthcare system, the lowest number of bariatric tourism. And maybe that's the way to go to enable people coverage, and in most European countries we do have coverage for bariatric surgery, public healthcare coverage.
Well, I think majority of the points are already been discussed, but I would again echo the thought of accreditation. Like US has the JCI, UK has the UK Forum, and I think there are only 4, I googled up and read about it, there are I think only 4 or 5 big countries which has good accreditation centers. That should be globally in all the countries, strict with that, certified surgeons, because I think in this era and the cost difference, you could see 80% of patients would just go anywhere because of low cost. So I think it is going to be unavoidable if I am offering in UK 15,000 pounds and that same patient goes to Turkey and gets it done for 2,500 pounds. So it's going to be unavoidable. I think we just need to regulate it better. Other point, what I would probably, from the patient perspective, is they need better education. We really need, I had a patient just 2 weeks ago who said that she had, I won't say that where she had it, but she said she had a band. We did an endoscopy, she actually had a mini gastric bypass. Other lady, 2 weeks ago, had a balloon in Prague 1.5 years ago. No idea. She said she was not told when to remove it. She came to us 19 weeks pregnant, hyperemesis, dehydrated, vomiting, ended up in the obstetric unit. And I think in the history somewhere somebody came up and found that she actually had a balloon. And I had to do an emergency balloon removal. So I think patient education is an important point along with, yes, the accreditation as well.
So I have a question for Dr. Bermoni. From your experience, how important is accreditation for the patients? Are they looking for accreditation or accredited centers or just price?
Well, that's very important to know. The patient, the most important for the patient is the reputation of the doctor. They try now to find all the history of that doctor, how many cases, but they don't know if they have certification, recertification. They don't look for that. Usually patients make the research, and after that, try to contact another patient or in another forum if somebody knows something about any doctor. In our case, in Tijuana, in Baja, we are almost 80 surgeons who do bariatric surgery. And this kind, when patients trying to find, they say, oh, this doctor have 3 years working, but 3 years ago was working with that doctor. Oh, maybe he had a good experience, because new doctors offer the procedure for low cost. And I have almost 25 years working in this area, and my price try to maintenance and the same. But the new doctors try pushing with low cost, And they say, when somebody asks me, doctor, do you have this? Yes, I have certification, I have everything, but the most important, the patients is they try to find the reputation, but the doctor by another friend. They find now the forum, the social media has helped a lot in this case. Mandatory certification is, they don't know about that.
So again, so you agree that we need more education for the patients in order to look for a better care. Would anyone like to make a... Yes.
Sorry to interrupt, but that is interesting. I just presented as a part of this. I have 41 patients with bariatric tourism in my London hospital. So we audited that data and presented it yesterday. So contrary to what you think, out of 41, 40% of the patient did not even know the name of the surgeon. They just went because of low cost.
Okay.
40%. You ask them, which surgeon? No idea. Why did you go? My sister paid 2,800 pounds.
In my case, all my patients come by referrals. That's in my case. And they know me very well before to arrive with me. That's
okay. We would like to have a final comment. Go ahead, please.
If we think the other way around, so patient, we agree that they go for the lower cost. We know that. In our guidelines, we have to persist that the standard of care. It is the one who, why I am expensive, why your price is expensive. We have in the guideline classify class 1, and we cannot be the same. You are 5 years experience, I'm 20 years, it's 35 years. So we have to consider in guidelines the experience. Most of the patients come, they said, why the price is here is very high. I tell them always this story. Picasso, he's a very famous, he was in the mall and he found a lady. She said, oh, Picasso, please make me a draw. He make her in 30 seconds, very nice one. And he said, okay, pay me. She said, how much? He said, $100. She said, $100 for 30 seconds. He said, I stay 30 years to learn to make it in 30 seconds. So they understand, oh, okay. There is a big factor, which is the experience of the surgeon. It's not free. Experience of the surgeon, because it's a good quality, good outcome. So we have to educate the patient that you have to look for the experience of the surgeon, and the center you are operating on, the outcome is directly related to the high quality center and a good surgeon. And also we cannot tell all the surgeons charge this. As you said, my resident or my trainee, after few years he will make it lower because he will. But we have to insist in a good experience. We consider it that experience of the surgeon and the center. The center it costs, the quality is cost. It is not easy with the high standard nurses, high standard operating room, high standard material. It costs. So we have to insist the quality, because the outcome depends on the quality and the standard of care.
Well, I bet you are hungry. We learned very much from you. Thank you very much.